Hello, everyone. Firstly, I would like to apologize for not being able to attend this meeting physically because of an emergency. My mom is not well and she's been admitted to the hospital. So I've recorded this video in replacement of my lecture. So my topic is on overcoming sexual dysfunction in the treatment of BPH as well as LUTS. So we know there are various treatment strategies for the management of BPH, and the aim of this treatment is actually to balance between the symptoms relief and benefits of this disease progression as compared to the side effects, quality of life, and sexual function due to this treatment. And we doctors often under-recognize this sexual dysfunction in men with BPH and LUTS. And if you ask the patients, 50 to 60% of these patients actually, if they know that the treatment causes ED or ejaculatory dysfunction, they would not agree to the treatment, even though this treatment may actually improve their urinary symptoms. Counseling on sexual adverse events, on the other hand, also has been shown to actually generate a higher rate of sexual dysfunction being reported than there's no counseling. And this is known as the nocebo effect. So treatment of LUTS BPH can be medical and surgical. Let's go into the medical treatment first. So we have the 5-ARIs or the 5-alpha reductase inhibitor for enlarged prostates, but it has the side effect of decreased libido, gynecomastia, erectile dysfunction, as well as ejaculatory dysfunction. We also have the alpha-1 blockers, which does not adversely affect libido, but it may actually cause abnormal ejaculation. It's previously believed to be mainly retrograde, but now has been demonstrated to be actually due to the decrease or absence of seminal fluid during ejaculation. This is a systemic review as well as a meta-analysis looking at the impact of medical treatments on BPH LUTS on their ejaculatory function. So what was found in this, you can see in this graph first, the alpha blockers which are more urospecific, more urospecific, like tamsulosin and silodosin, as compared to placebo, you can see that it causes more ejaculatory dysfunction as compared to those alpha blockers which are not uroselective, like doxazosin and tarazosin. In fact, at a multivariate analysis, it's been shown that improvement of both urinary symptoms and urinary flow rate, in other words, when there is improvement in their urinary problems, it's been associated strongly with the occurrence of ejaculatory dysfunction. So when they get better improvement in their urination, there's also a worsening of their ejaculation function. Now, when we look at the 5-alpha reductase inhibitors like finasteride and dutasteride as compared to placebo, this finasteride and dutasteride actually does not really cause so much of this ejaculatory dysfunction. Looking at combination therapy, when we compare them against alpha blocker and the 5-ARIs, you can see from the first at the top there, the alpha blocker causes more ejaculatory dysfunction as compared to combination therapy. And surprisingly, also, you can see the 5-ARIs causes more ejaculatory dysfunction as compared to the combination therapy. This is a prospective randomized placebo-controlled study looking at the combination therapy on the sexual functions of patients with BPH LUTS. And what was found was that there is a decrease in the sexual function, but when they look at the domains in the questionnaire, they found that the erectile function is not so much affected. What was affected more was actually the ejaculation part. So the domain of the ejaculatory dysfunction was much greater as compared to the erectile dysfunction. So if a patient comes to you with erectile dysfunction, we should actually consider pharmacotherapy for the erectile dysfunction if required, and this includes PD5 inhibitors. But if the patient comes to you with ejaculatory dysfunction, we should consider switching the BPH LUTS therapy using alternative alpha blockers of 5-ARIs. Another option for patients with both erectile dysfunction as well as BPH LUTS is to use the low-dose tadalafil, daily tadalafil. And it's been shown that low-dose daily tadalafil improves erectile function as well as improving the LUTS symptoms as assessed by the APSSM score. Now we look into the surgical treatment for BPH LUTS. We know that the cavitating BPO surgery like TURP as well as laser surgery has a well-established adverse effects of causing absent or diminished ejaculate volume. In this systemic review and meta-analysis, looking at the impact of surgical treatments on LUTS, and the treatments that were studied were QRP, PKRP, the holmium laser enucleation and resection of prostate, the photoselective vaporization of prostate, thulium laser, open prostatectomy, as well as laparoscopic simple prostatectomy. And the results were mixed. In direct comparison, all these surgical treatments did not decrease post-operative IIEF score. In fact, some of this treatment actually shows increased post-op IIEF score. In other words, there is improvement in their erectile function in some of these treatments. In those that showed the lower IIEF or there is worsening of the erectile function, these effects are usually short-term. This is a systemic review looking at the minimally invasive surgeries treatment for BPH. And the treatment that was reviewed were the transurethral microwave therapy, transurethral needle ablation of the prostate, transurethral eternal ablation of prostate, as well as the HIFU or high intensity frequency ultrasound. And what was found was that minimally invasive surgeries had comparable effect to TURP on the erectile function. There is high incidence of ejaculatory dysfunction in laser surgeries, whereas TUMT, TUNA, and the less effective laser surgeries have less incidences of ejaculatory dysfunction. So besides these, in the past few years, we have also newer treatments, newer minimally invasive treatments for BPH LUTS. And this includes the prosthetic urethral leaf. And in early studies, what was shown when they compared to TURP, the erectile function was preserved in both arms, whereas the ejaculatory function was superior in prosthetic urethral leaf as compared to TURP. We also have the Resume system, which is using water ablation. And in the first study, there was shown no cases of de novo erectile dysfunction, and the impact on ejaculatory function was not clear. We also have the aquablation using water jet to cut through the prostate. And in this Cochrane review, Cochrane library, what was found was that there was little to no difference in erectile function, but it offers a small improvement in preservation of the ejaculatory function. The interventional radiologists as well wants to come to the picture, and they have also introduced the prostate artery embolization for the treatment of BPH LUTS. And in early studies, they have also shown that the erectile function does not decrease or does not worsen with this prosthetic artery embolization. This is a review which was published in the Sexual Medicine Reviews, looking at all the newer treatments for BPH. And this includes the aquablation, Urolith, and Resume. And what they found was that aquablation and prosthetic urethral leaf were able to demonstrate permanent sexual function preservation. And this includes the erectile function as well as the ejaculatory function. In this systemic review, looking at new ultra-minimally invasive surgical treatment for BPH, the conclusion that they found was that only Resume, Urolith, and the prostate artery embolization had a minimal effect on patients' sexual function. Other ways to try to preserve sexual function, especially ejaculatory dysfunction, in BPO surgery, in benign prostate obstructive surgery, is to modify the surgery itself. And it's been shown that by modifying this surgery, you may be able to reduce the erectile dysfunction and ejaculatory dysfunction rates. And what they mean by modifying this treatment is actually a modification of the surgery where we preserve part of the supramontanal prostate and prostatic urethra for more than 1 cm from the verum montanum. Another new minimally invasive treatment that can be done under local or sedation is this ITIN, or what is known as the temporary implantable nitinol device. So this device is implanted into the prostate and it will expand, and as it expands, it twists and sort of like gives a pressure necrosis and cuts through the prostate. And in the evaluation which was done, what was found was that there were no changes observed in sexual and ejaculatory function of patients who were given this ITIN. This is another table which is taken from a paper which was published by Prof. Eric Chung. I think he'll be talking again on all this minimally invasive treatment for BPH in more detail. We await his lecture. And you can see from this table that there are so many minimally invasive treatment available for patients. And this includes things like the Memocare or the prosthetic stent, as well as Botox. So, in summary, when a patient presents with BPH or LUTS, his treatment should be individualized, and it should be a shared decision-making process. So we need to look at the patient's preference and discuss with him the different treatment options, the pros and the cons. What I suggest is that for medical treatment, if the patient has erectile dysfunction as well as LUTS or BPH, we can give a patient the low-dose daily tadalafil with or without the 5-alpha reductase inhibitor. If the prostate is enlarged, then yes, we need to add in the 5-ARI. And if there's a problem of ejaculatory dysfunction, if the patient is young, there's a less side effect of this hypotension, then we can actually use the less uroselective alpha blockers like alfuzosin. And for surgery, for patients who are concerned with their sexual function, the newer minimally invasive options would be a better option for these patients. And with that, I thank you for your attention and would like to invite everyone to the Men's Health World Conference, which will be held from the 11th to 13th December 2023 at Kuching, Sarawak. Thank you for your kind attention.